pleasure to welcome our guest speaker for this afternoon, Frank Larkin, who's a colleague from UK, working as a consultant at the Moorfields Eye Hospital, will give us an update on Acanthamoeba keratitis.
Thank you, Harminder. It's quite appropriate to have a presentation from Europe about this disease because we see lots of patients with Acanthamoeba keratitis. In my hospital, we have seen at least 100 new patients every year since at least 2010. And most of those patients are generated in our own emergency department, so that they're not referrals. So we've got a lot of experience with this keratitis, to which Jesper has already alluded. This is a completely different pathogen of the cornea to everything else. It's very large and it's very complex. One of the Acanthamoeba genomes was sequenced a long time ago, 12 years ago. How many genes does an Acanthamoeba have? 15,500. A bacteria, 200. A virus, depending, 750, 800. Amoeba, 15,500. Human beings, how many genes? About 20,000. These pathogens have more in common with us than with all the other pathogens that affect the cornea. So they're complex, and I think that partly explains why treatment is difficult. Two forms of the organism, and this is key to the poor therapeutic response in some patients. The amoeba, in adverse environmental conditions, can adopt a double wall, which is highly resilient to physical things, temperature, shortage of food, and resistant and resilient in the context of therapeutics also. The association with contact lens wear is enormous in Europe, not as common in India, common in North America. The vast majority of the patients we see in Europe are contact lens wearers, all types. And we know from separate studies in Bristol in the west of England, in London, and in the United States, that domestic tap water in sinks and in showers and baths is the most common source of amoeba in the patient's environment. This is work done. The date of the publication is 1990, 35 years ago. We discovered that tap water was a source of amoeba, and we're still having problems with this disease. Imaging and the developments in imaging of the cornea have been very helpful in diagnosis, in particular in vivo confocal microscopy. The typical clinical features are listed. Quite a lot of photophobia, in common with all forms of keratitis, epithelial or stromal disease, with different clinical pictures becoming evident with severity of disease and more advanced and progressive disease. The problem cases, the patients that do not get a good response to infection, are the patients in whom pain is very difficult to manage, and that's uncommon. The patients with scleritis or necrotizing corneal perforation, both uncommon, and the patients with posterior segment involvement, and that's very, very uncommon, such as the patient whose fundus is photographed on the bottom of the slide with attenuated vessels. This is a picture very like central retinal artery occlusion without the cherry red spot. Flatty orgy. These are unusual Acanthamoeba patients, but they are exceptionally difficult to manage. And of course, in the context of retinitis, there is no prospect of restoring vision. Diagnosis, unlike what Professor Hjortdal said a few minutes ago, we value culture very much, and we do try to culture amoeba in all the suspected cases that we encounter. Having said that, in London, it's confocal microscopy and PCR that really establish the diagnosis in most of our patients. The great advantage of confocal microscopy diagnosis is that it is immediate. you can start treatment without delay. And this is one of only 2 infections of the cornea in which confocal microscopy is really helpful, the other being filamentous fungus infection. So you've got an immediate diagnosis. We always, in suspected cases, would advise taking a specimen of the cornea for PCR and taking a specimen of the cornea for culture. But we would start antiamoebic treatment directly once we see cysts on confocal microscopy. You can then await the laboratory results from the PCR and the culture. If a patient has a confocal microscopy diagnosis, negative PCR and negative culture, I would be very careful in an Acanthamoeba diagnosis in that patient. So if the patient does not respond to anti-Acanthamoeba treatment and you only have a confocal microscopy diagnosis, think about other causes of chronic stromal keratitis. And you know them all: viral disease, microsporidia, etc. There are many. Antiamoebic agents. This is the area where we need an update, and there is none. If you look at the dates of the publications here, the first antiamoebic was Broline, which I'll show on the next slide. Discovery, 1987. Polyhexanide, PHMB, 1992. Chlorhexidine, which is the same molecule, a shorter number of polymer units, 1995. There has been no progress in therapeutics for this blinding keratitis of note since those years. Nothing. So an update on Acanthamoeba keratitis is, in that respect, a very short lecture. What do these drugs do? The biguanides cause lethal structural and intracellular damage to trophozoites, but also to cysts. And you must have an agent that is cysticidal for effective anti-Acanthamoeba treatment. So that's vital. There are no reported cases of cyst resistance to polyhexanide or to chlorhexidine. There have been none. But we do not in all cases get the therapeutic response expected. So in Moorfields, we will typically start with a biguanide monotherapy, commenced very frequently for the first 2 days, hourly day and night, certainly hourly throughout the day, and reduce the frequency with a maintenance dose. Treated until the patient has a white eye and not taking steroid. So that's a question that commonly comes up: how long do you treat with antiamoebics? I'd say when the eye is completely uninflamed and the patient's not taking steroid, if steroid has been used. Monotherapy is successful in most. I'll give you data in a moment. Steroid in Acanthamoeba keratitis, very helpful if there is intraocular or limbal or scleral inflammation of significance. So in Europe, generally, clinicians will give steroid in those clinical circumstances. In North America, they are not used. And I think that question does need to be resolved. We believe steroids are helpful, and I use them readily if there is inflammation which justifies that. For those patients with scleritis, as with scleritis from any cause, you need systemic immunosuppression to control the scleral inflammation and the symptoms resulting from the scleral inflammation. Now, in which patients would you expect, and can your patient expect, to have successful medical treatment without recourse to surgery? The first thing is early presentation. Certainly if a patient presents with symptoms of duration 2 weeks or less, they should get a very good response. They don't all, but you'd expect them to. Steroid should not be given in these earliest weeks. As in so many causes of infectious keratitis, hold off on steroid. In this disease, as much as in any. In those patients with what we would term unresponsive disease on medical treatment, a common scenario is a patient with continuing symptoms, continuing inflammation, and you need to resolve the question, is this due to resistance of persisting amoeba, or is this due to inflammation in an eye in which there are no more surviving amoeba? You already have cure of the amoebic infection. And the strategy there is to take a corneal biopsy and culture. If the culture is negative, that tells you you've got amoebic medical cure and the treatment needs to be directed at the secondary inflammation. If the culture is positive, that tells you you've got uncontrolled amoebic infection and your treatment is going to be more difficult because you've already been treating with anti-amoebic agents without success. And they are very, very difficult patients in which to get disease control. So these patients in whom there are problems and in which you've got to look at alternative treatments tend to be those with deep disease, deep corneal disease, possibly extending into the sclera, which is a bad prognostic sign, as in any keratitis, and those patients with late presentation who usually do have deep disease. And in those patients, other than biopsy, you're looking at possibly needing a tectonic keratoplasty or an excisional keratoplasty to get disease control, in the hope that you do not have immediate recurrent acanthamoeba infection post-keratoplasty. And that's the big problem. Audit of cases. These are Moorfields data from 3 years ago, 196 cases, medical cure in the majority of patients, 36% scleritis, secondary bacterial infection. Look at the high figures, 18%, 11% corneal perforation. These are not very good results, and in a center where we have a lot of experience. Median duration of treatment, 6 months. So tell every patient in whom you make a diagnosis of amoebic keratitis, you could have an extremely long treatment course. I tell them all, and I tell them they may lose vision. Better to tell that to the patient initially, not tell them when they're complaining 5, 7 months, 9 months down the track that they never realized they had such severe disease. Good vision in more than half the patients, bad vision 17% in this large group. So the prognostic factors for good outcome, I've told you, early presentation, short duration of symptoms prior to establishing the diagnosis, and avoidance of steroid prior to 2 to 3 weeks at least post-diagnosis. The most recent clinical trial is of polyhexanide 0.8% versus polyhexanide 0.02% combined with propamidine, which is Brolene. There was no difference between the two groups, and the medical cure rate was about high 80s%. Generally good results and equivalent in both treatment arms. Just be aware that nobody anywhere has done a dose response curve of PHMB. That agent was first used at that dose of 0.2% without any evidence that that was the best dose or the best concentration. That's not the way we approach antimicrobial chemotherapy usually, and that was just based on patient comfort. So I think a lot more needs to be done on therapeutics, including looking at alternatives. And I just want to finish with this. This is from India, bottom half of this slide, miltevosine, an anti-leishmaniasis drug, 5 patients treated, extremely poor results. But I commend the investigators. It was in LV Prasad here in India, because at least they're doing some kind of analysis of the pathogens and making a rational choice and looking at new agents, which I think we need to be doing in more big centers. So this was not a successful introduction into the armamentarium, but I'm hoping it will be followed by more. So to conclude, include Acanthamoeba in the differential diagnosis of any chronic stromal keratitis, especially in a contact lens wearer. Be particularly aware of assumed non-resolving HSV. Be aware of the diverse early appearances of disease, untreated scleritis, superinfection with other pathogens, and always inform patients about a possibly very severe disease course. Thank you. I hope you find that helpful.